続きまして、ベンウィーク2026企画 ジャパン・タイランドジョイントセッションを開始いたします。座長は日本静脈学会理事長毛先生、第2川崎幸クリニック白杉先生です。座長の先生方、よろしくお願いいたします。
皆さん、じゃあお席についていただいてよろしいですか。そろそろ始めますよ。よろしくお願いします。And we will start the Vein Week 2026. The Vein Week is a kind of the event to promote the vein practice around the world. And there is a lot of the Vein Week event all over the world. And this year, we Japanese Society of Urology and we Japanese have a collaboration with Thailand, doctor from Thailand. And Thailand is we Japanese people have a long friendship for a long time ago. And we have 4 Thailand doctor to this meeting. Welcome to Japan. And I hope you enjoy a hot spring around the Kyushu area. This is a very good hot spring area. Yes. So, and the chairperson is my name is Makoto Mo, and Japanese Society of Urology are present. And instead of Dr. Imai, and we will have.
Good morning. My name is Nozomu Shirasugi from the second Kawasaki Sawai Clinic.
And we have a Japanese discussion, and we will start the presentation. And the first speaker is what?
Okay. Our first speaker is Dr. Nuttaut Samsatana Sawari from Sirat Hospital, Mahidol University, Bangkok. And the title of the presentation is Complications of Cyanocarite Closure of Saphenous Vein Reflux. So, Dr. Samsatana Sawari, please begin your presentation.
Good morning, everyone. I would like to say thank you to Professor Mo, Professor Okawa, Professor Iwai, and Dr. Imai also to invite me to be here. My topic is complication of cyanoacrylate closure. I have no disclosure. As we know that the cyanoacrylate closure or glue ablation is one of the NT for the saphenous vein ablation. And this is the benefit of the cyanoacrylate closure. There's no risk of nerve injury, no need for the tumescent anesthesia, and no need for the compression after treatment. But there are some complications that we should know before performing the patient. The first one is the hypersensitivity reaction, or HSR. Alternative name is the Febretic slide abnormal reaction, or PILA. This is the type 4 of the hypersensitivity reaction. It's a delay immune cell response mediated by the T cell. And this is the incidence of the HSR. This run from 6% to 25%. In my country, about 16%. And presentation of the HSR is usually the erythema, like this, and itching is the main symptom, but sometimes pain and sometimes swelling. This is different from the classic thrombophlebitis that usually pain and swelling first. And for the HSR, it usually occur in the skin overlaying the treated vein, and it occur about 2 weeks after operation. And this is the risk factor. The first one is the suprafacial grade saphenous vein of the length more than 10 centimeters. In our series, we found that suprafacial truncal vein with depth less than 1 centimeter from the skin and the size of saphenous vein equal or larger than 8 millimeter are the risk factor of the HSR also. If the patient have the redness only, we classify as the mild HSR, and we just observe or prescribe the antihistamine or NSAID for treat the mild HSR. If the symptom persists, we classify as the moderate HSR that require oral steroid to treat it. If the symptom prolong more than 30 days, we classify as the severe HSR that require the vein excision, but it's very, very rare, just only 0.3%. Another complication is the granuloma. In our theory, we found 3%, and the patient present with abscess at the puncture site that occur around 3 months to 5 months after operation. But it occurred before the new IFU of the Medtronic. The new IFU now recommend to recapture of the glue delivery catheter within the long sheet before removal of the last dose of the glue is applied. So we never found the glue granuloma again after we follow the new IFU of the Medtronic. The next complication is the EGIT, that endovenous glue-induced thrombosis. For the EGIT, if the glue plus the thrombus that protrude into the deep vein, that first described by Dr. Cho, and incidence is around 6%, and the risk factor is the vein diameter is less than 5 millimeter. When we look at the ultrasound for the EGIT, it displays like the more echogenicity on the ultrasound, and it occurs immediate after operation because when we perform the glue and the glue is polymerization, so we can find the EGIT immediate after operation, and if it's left regression is component of the glue, not only the thrombus. This is the theory of the show that you can see that if it's no change or small regression or very slow regression because it's the component of the glue inside. And also show the treatment guideline for the EGIT. For the EGIT 1 and 2, just observation, and 3 and 4, they require anticoagulation. However, there are no consensus of the treatment of the glue extension into the deep vein now. We found another complication that may be similar to the EGIT, but is some different. I describe the term thrombus extension after CAC or TCAC. This is the pure thrombus extension like the EHIT. There are no glue component like the EGIT. And the incidence is around 5% and easy regression, but we don't know the risk factor now. You can see that after we put the glue from here, there are some thrombus extension into the deep vein like this and this. We found at 1 week after operation, so we classify the TCAC like the EHIT. For the TCAC 1, the thrombus extension from the glue site into the saphenofemoral junction. And we found that there no required treatment like the EHIT also. For the TCAC 2, the thrombus extension into the deep vein less than 50%, we call the TCAC 2, and just serial ultrasound is enough. And for the TCAC 3, the thrombus extension into the deep vein more than 50%. I recommend to prescribe the therapeutic anticoagulant until it disappears. For the TCAC 4, the thrombus extension into the deep vein for the total occlusion of the deep vein, and we treat like the deep vein thrombosis for 3 months. This is the photo of the TCAC. You can see the TCAC 3, the thrombus extension into the deep vein more than 50%. That occur 1 week after operation. After prescribe the DOAC for 4 weeks, you can see that the thrombus disappear. So this is slide show the difference of the EGIT and TCAC. For the incidence, it's around 5% both, but the component of the EGIT is glue and thrombus. For the TCAC, it's only the thrombus. And the onset of the EGIT is occur immediate after glue injection. For the TCAC develop later, usually 1 week after operation. And EGIT is difficult to regression, but for the TCAC is easy regression. And EGIT is no response or less response for the anticoagulation. For the TCAC is well response. For the EGIT, we know the risk factor for the vein size smaller than 5 millimeter. For the TCAC, we still don't know now. So, in summary, which truncal vein is not suitable for the glue? If the vein size is smaller than 5 millimeter, it's the risk of the EGIT. If the size is larger than 50 millimeter, maybe the risk of incomplete occlusion. And for the depth from the skin less than 10 millimeter, is the risk of the HSR. And in the GFV that have the previous superficial vein thrombosis, they are only the thick wall, they are the risk of incomplete occlusion, and we should avoid to perform the screw in the patient who have the history of allergy of cyanoacrylate. For the take-home message, screw have many benefits. However, complication could be found, but most of complication could be prevented and treated. And patients should be informed about the possible complication before surgery, and we should following the IFU from the company. Thank you for your attention.
Thank you very much for your excellent presentation. And now we would like to invite the discussant to make brief comments on this presentation. The discussant for this presentation is Dr. Kensuke Takeuchi from Takeuchi Vascular Clinic. So,
Dr. Natat, thank you for giving an informative and convincing presentation. As you mentioned, I also believe that CSC is a very beneficial method. My question is regarding HSR. I think the incidence of HSR varies depending on the climate. Concretely speaking, I have the impression that HSR is more common during the humid rainy season and the sweaty summer months compared to the cold winter. Thailand also has a rainy season. Do you have any opinions on the relationship between climate and the incidence of HSR?
Thank you for your question. This is important point also. In Korea, they report about 25%. In Thailand, only 16%. Maybe the climate, different climate between Asian country also maybe not relate to the incident of the HSR. However, in Asian country, we found that extrafacial vein from the GFV that protrude above the fascia is more common in Asian people. So this is maybe the explain that why it's more common in Asian country than European country.
Thank you.
One comment for me. And in Japan, we publish a national-wide survey of the complication of CSC. And localized phlebitis, which require the treatment, is about 7%. And among the more than 24,000 Japanese patients, it's about a 1 year period, I think, one or 1.5 year period at the beginning of Japanese interaction. Maybe this will be a good example of the Asian population complication. Yeah, it is published in JVS. Yeah, last 2 years ago.
Thank you very much.
thank you very much, Dr. Mo. And does anyone have any questions? Please.
You showed was I'm wondering if the thickness of the vein wall affect the result.
Yeah, because if the vein wall is thickness from the previous thrombosis, it's difficult to compress. That when we inject the glue, we have to compress, all right, to make the vein collapse. Yeah, but for the vein thickness, sometimes when we compress, there's not collapse. This is the make that I make in the slide that may be difficult to use in the previous SVT before.
Thank you. So
maybe I prefer the thermal ablation. Yeah, thermal ablation may be better.
Okay, thank you very much, Doctor.
Thank you very much. Next speaker is Wachai Sensei and Dr. Sengulagwai and from Bajara University Hospital. And the venous thrombectomy for the deep vein thrombosis, when and how? Yes, please start.
Good morning, everyone, and thank you for the VNAT talk committee for inviting me to share the venous thrombectomy for deep vein thrombosis, when and how. This is my disclosure. As you already know that in the iliofemoral DVT, it have more chance to have the severe symptom and also have more chance to recurrent compared with the FEMPOP. And also at 2 years have a chance to have the post-thrombotic nearly 50%. So in my practice and also in international guideline, the thrombus removal nowadays we do in the case that have the two reasons. First, to relieve the severe symptom, for example, the impending limb thickening in phlegmasia cerebrorum. And second, to reduce the severity of the post-thrombotic syndrome. So if we look at the risk factor for the PTS, besides from the iliofemoral DVT, the residual thrombus after 3 months of anticoagulant is one of the risk factors. And why we propose the open vein theory to remove the thrombus early by remove the thrombus. So this is a hallmark study in the past that compares standard treatment with cross removal. The current trial that shown the CDT can reduce the PTS at 2 years and 5 years compared with standard treatment. Even the quality of life is not different. And the ATTRACT trial compare also the standard treatment with cross removal, but cannot show the difference in PTS. But in subgroup of the iliofemoral DVT, the cross removal can reduce the severity of the PTS and also can improve the leg symptom early with reduce the venous disease specific quality of life, and also have a bit major bleeding and any bleeding compared with standard treatment. So we can say that in international guideline, the candidate for thrombus removal we can categorize into 3 groups. First, for the acute limb thickening from the DVT, like impending venous gangrene. The second, to reduce the PTS, the severity of the PTS in selected case in iliofemoral DVT with symptom less than 2 weeks and have a good functional status with life expectancy more than 1 year and low risk of bleeding. And the third group is the patient that after on anticoagulation, maybe 10 or 2 weeks, but the symptoms still have moderate to severe. So in Thailand, and also we have option by endovascular, and shown on the slide, can do the large bore mechanical thrombectomy, or you can use aspiration like indigo system or rotational thrombectomy. And overview before operation, we do the CT abdomen, also CTA of the pulmonary artery to check of the PE before start the operation. And of course, anticoagulation, we use as usual, usually use the unfractionated heparin or low molecular weight heparin. And we not routinely put the filter, only in the case, for example, free floating proximal thrombus that put the filter, and the access usually at the same access at the same leg, not directly access at the clot. But in some rare case, we come crossover or even directly access at the clot in some cases. And remove thrombus as much as possible. In some study, if you can remove more than 90% of the thrombus, the primary patency shown better than less than 50% of the thrombus. And very important to check with the IVAS after remove the thrombus to check the culprit lesion. If it's more than 50% stenosis, we have to do angioplasty or put the stent. And of course, post-intervention is very important that my friend will talk later. For the IVC filter, we selected in case that shown the thrombus like in this case that's floating and no compression at the maternal is have a chance to have a PE during the case like in this case. I will show you that the thrombus at the external control, but in this case we put the filter and then we can remove after that. And I will show you this case is a young left leg swelling, not the symptom is moderate to severe. Of course we can use just anticoagulant, but we discussed with the family, we did the data we gave about the post-thrombotic. The family decided to do the thrombus removal. We access at the femoral vein. You can see here that the thrombus at the iliofemoral extension. And the vein, the blood not go to the iliac vein, go to the collateral. And usually my prefer is aspiration with the indigo system, 8 or 10 friends. And after remove, we check with the IVAS. You can see here in the septum in the vein, it means this case is not there. Maybe this case have previous DVT and have the post-thrombotic. And then we do the angioplasty with the 18 and 16 and 14 balloon, and this venography shown after angioplasty. The flow is go up. Residual stenosis at the external but less than 50, so we decided not put the stent because it's a young male. And this is after the operation. He can go back to school less than 1 week and still on anticoagulation. This 3-year follow-up already, still no recurrent, and the Villita score is less than 5. So in conclusion, anticoagulation is the mainstay of treatment, but thrombus removal increase the benefit, but in selected case of iliofemoral DVT, to reduce the symptom, reduce severity of the PTS, and improve venous disease specific quality of life. Thank you for your attention. Yeah.
Thank you very much for presentation. We have a discussion. Dr. Hayashi, please.
Thank you for your great presentation. I'm Hiro Hayashi from National Cerebral and Cardiovascular Center. I have one question about venous stent in Thailand. So how do you decide which patient needs venous stent after thrombectomy? That is to say, do you also use venous stent in younger patients?
Okay, thank you for your question. How after thrombus removal we decided put stent or not put stent? We look at the inflow. If the DVT is descending, it means is thrombus only in the iliac and fem-pop is free of thrombus. In this case, we put the stent. But in this case, the ascending DVT is mean you cannot, the inflow is not good. You cannot remove the flow in the fem-pop. In this case, we just do the balloon, not put the stent, because otherwise it's come back with a rethrombosis after that. So we look at the inflow. Yeah, but in the second question for the young patient, we try to avoid the stenting as much as possible, like in this case. Yeah. So.
Thank you very much.
Any other questions from the audience? Yes, I have one question. In Thailand, which device is approved? I saw you were using maybe Cat8. Is that Cat8?
Yes.
And
yeah.
what kind of other device is approved in Thailand?
Okay. We got approved 3 devices. The first one is Cotriver and Indigo and Aspirate.
Indigo, Aspirex.
Yeah, as a 3 devices. Yeah.
And is officially approved at the insurance covered or not covered?
No, not reimbursement. The patient have to pay by themselves.
I see. I
Yeah.
see. In Japan right now, we have two approved thrombectomy device, inari device, and penumbra device. Penumbra is just Cat 8, but it's a small device, and we also have a one stent system. Right now, we are doing post-market research about 100 cases, and we have those kind of results, but officially approved by Japanese government. Yeah, I hope we can share those kind of information with you. Yeah, thank you.
Yeah.
Any other questions? Yes, thank you very much. Arigato. So next speaker is Dr. Surikwe, and from Landi Hodi Hospital. Maybe my pronunciation is not good. And how do I treat a post-traumatic syndrome patient? Yes, please start.
Thank you for inviting me to present the topic of the how do I treat the post-traumatic syndrome patients. The PTS was manifested of the clinical of chronic venous insufficiency or the venous claudication. The diagnosis based on the clinical after the acute DVT phase, at least 6 months, and the severity of disease using the Villatas score. If score more than 15 or the patient have the venous ulcer, indicate to the severe disease. And you can see the risk factor for the PTS development, the thrombus extension that includes the common femoral vein up to the vena cava is a high risk of the PTS. For the PTS management, we always begin treat with the non-operative approach for all patients that include the supervised exercise training, compression stocking high pressure, and the venoactive duct. And the conservative treatment is towards quality of life improvement for the iliofemoral or the iliocaval chronic venous obstruction, more than the thrombosis isolated at the same population. So we consider the operative treatment in this thrombus extension. And we prefer endovascular treatment strategy first because there are low morbidity and also have the good stent patency and improve quality of life. And the indication for the patient that have the clinical stage C4 to C6 and some selected patients that have the C3 that excluded of the other causes of the edema. And the patient have the moderate to severe PTS with a significant disturbed quality of life or disturbing venous claudication. Before the intervention, we use the duplex scan to evaluate the info. Info means the common femoral vein, or the profunda vein. This picture look at the fibrotic chain in the profunda vein. That is mean this cat is the unhealthy segment of this vein area. And the duplex scan can help you about the panning for the puncture site. And the second investigation is the axial imaging that to do the identify disease segment that evaluate the info such as the iliocaval thrombus extension and excluded of the other cause of the compression such as a tumor. And this figure show anatomical classification of the chronic venous obstruction that's proposed by Professor Jialai. And you can see the good result of the endovascular treatment in the type 1 to type 3 because this one is at least one good info from the femoral vein or the profunda vein. And on the contrary, you can see the type 5 that the thrombus extend to the femoral vein and profunda vein is only 5% of the stent patency up to 2 years. So the patient with the info type 5 should not be treated for the endovascular treatment and endophlebiectomy. And we prefer the conservative treatment first. For the concept of the intervention, the successful depend on the multidisciplinary team, and we need to discuss to the patient about the compliance for the surveillance protocol and the anticoagulant treatment during the operation and post-operative treatment. And the 3 factors for the stent failure that include the technical error or the hematological problem of the anticoagulant and the fall. The fall that I present is important for the info in the previous slide as well. For the procedural step of the iliac vein stenting, we prefer the adequate hydration and use the general anesthesia because the post-traumatic disease is the long segment of the fibrotic chain. So if you do as a local anesthesia, the patient have the severe pain. And the puncture site is the ipsilateral midfemoral vein. We need to prepare the backup of the right internal thoracic vein approach for the causes lesion if you cannot passing the lesion through the leg up to the IVC. And during the operation, we use the IPC for calm muscle pumping, and we maintain the heparinization with the ACT more than 250. And the key requirement is the IWAS that you should use with the combined venography. And the gold standard of the IWAS need to check to the landing zone and the stent apposition. We prepare the high pressure balloon and the dedicated venous stent, and you can see the table. This one is followed as the stent sizing in the international guideline ESVS. And in Thailand, we are available for the dedicated venous stent, such as a wall stent, AB stent, and right now we have the Sinus Optimate stent as well in the hybrid stent. This one is the demonstrated cases, one of the chronic left iliac vein obstruction. We check to the info and identify the lesion from the venogram, and then we cross-check the lesion, confirm that the Y into the true lumen, and check the outflow again. And then we use the IWAT to check the landing zone. And you can see this one is the IVC and downward to do the iliac vein, and you can see the fibrotic shade around here. And after that, we use the P-dilatation with the high pressure balloon. And then we perform the dedicated venous stent deployment and follow it by the post-dilatation with the high pressure balloon. And compression venography. You can see the good outflow up to the vena cava, and the collateral disappear as well. And finally, we use the IWAT to check the stent apposition and the contralateral gelling. This one shows you to do the stent is not involved the iliac confluence. And the post-operative treatment is the critical problem to maintain stent patency. The therapeutic anticoagulant, we prefer the low molecular weight heparin until the 2 weeks because it prevents the thrombus propagation, and the low molecular weight heparin is the benefit from the anti-inflammatory process. And we switch to the therapeutic dose of the DOAC at least 6 months, and then if the patient have the good stent patency, we change to the prophylactic dose. And the patient need to do the surveillance of the duplex scan as the protocol. This one I can show you about the duplex scan. You can see the iliac venous stent is patent, and the distal edge of the stent show you is above the femoral confluence, and the info is very good in the femoral vein and profundal vein. In the follow-up, you can see the significant reducing of the symptom of the patient with the limb swelling and the venous ectasia disappear. And we do this one until 16 months post-stenting. So, we conclusion about the PTS management. The goal is the getting it right the first time to reduce the failure of the stenting. And you need to know about the T-stent factor for the stent failure. And you need to do the technical precision, need the IWAS, avoid overlapping stent at the inguinal area, and prevent to the stent migration. Need to use the stent length more than the 100 mm, and proper for the anticoagulant treatment that my friend talk later. Thank you so much.
Thank you very much for presentation. And we have a discussion. Dr. Nishimoto, please.
Thank you. Great presentation. Sometimes we have cases with difficulty in passing wire because of the considerable shrinkage of iliofemoral vein, especially in patients with iliac compression syndrome. Do you have any tips for crossing the wire?
So I use for the stiff thermohydrophilic wire or OT5 first, and then I use some the crossing catheter, and I usually use the quick cross. And if I cannot pass the wire, I change the wire to the 058, C2O lesion, something like this. And it's not good for do like this. I approach in the ipsilateral. like internal jugular vein as well. Yeah, and sometimes I use for the contralateral femoral vein as well. Yes.
Thank you. Another question: do you have any patient with substantial pain after stenting in the chronic phase?
Yes, I have that. Before do the intervention, I talk to the patient about the back pain because the fibrotic chain is small lumen, and if you do the venoplasty and stenting, it open up immediately. And after the operation, I given the morphine IV or totally for the first day to the patient, and advice about the back pain is continue up to the 2 to 3 weeks and disappear.
Thank you.
Thank you very much. Talking about back pain, do you use, according to the European and American guideline, they recommend for common iliac pain 16 often.
14.
But compared to those people, we Japanese and we Thailand people and Asian people are small. So in Japan, we usually recommend 14 maximum. What do you recommend in your country? What do you perform in?
For me, the PTS patient, I always use the 14.
14, yeah.
Yeah.
Maybe we are small, so.
Yeah, I agree.
Yeah. And for me, I've been performing recently I usually performed only using 0.35 wire because we recently introduced Asahi cross read. Asahi Intec produced a very good wire, 035 wire. So I have a less chance to use a 0.14 wire anymore. And it's worth to use it once. And it's a Japanese product. I didn't get any money from them, but actually it's very convenient. And any other question about procedure? And in Japan also, we recently introduced a venous stent, venous stent and we just finished post-marketing research, and we are making research of that. And we have a very strict indication for the PTS. And in your PTS patient, how many % of patient is a candidate of the endovascular therapy?
So in Thailand, we use for the indication that I told you before. But sometimes here, right now, in the patient of Thailand, I recommended to do in the venous leg ulcer first for treatment to do the stenting if the patient have the chronic venous obstruction. And other patients, sometimes it's selected cases because in Thailand we have know about the government reimbursement for the venous stenting in some the patient.
Thank you very much. ありがとうございました. Thank you very much. And next speaker is Victor Sanction Singh and from Bajara Hospital. And anti-thrombotic after venous stenting. This is also very big problem in Japan too. Yeah, please start.
Thank you for the introduction. 皆さんこんにちは。Dr. Vacharapong from Thailand. Here is the example of my patients. The patient has CVI, C6, and post-thrombotic syndrome. She underwent stenting from IVC to external iliac vein. And I don't know why, but the patient stopped anticoagulant by herself. But fortunately, the stent was patent and the wound healed. For now, there is no evidence-based recommendations for anticoagulant management. From the systematic review, many protocol was mentioned in the studies. Most of them, they use therapeutic anticoagulation for 6 months. But if we treat the patient with acute or subacute DVT, they recommend to use minimum adhere to the existing VTE management guidelines. In the patient with non-thrombotic iliac vein lesion or NIVU, with or without anticoagulant may not important to about primary patency. For the dosage, no anticoagulant prophylactic dose or therapeutic dose, enoxaparin, warfarin, or rivaroxaban. All of these do not have difference in primary patency. In NIVU also, DOAC used for 3 months or longer do not show the difference in primary endpoint. But in the patient with NIVU and cancer, more stent thrombosis in the patient without anticoagulant. So anticoagulant is important in the patient with cancer. For the patient with post-thrombotic syndrome, long lesion, and some patient has hypercoagulability. They show that if we use low molecular weight heparin for a few weeks, start with a low molecular weight heparin, the primary patency is better than anti-factor Xa inhibitor or warfarin. And when compared rivaroxaban and warfarin, rivaroxaban seems to have a little higher patency when compared with warfarin, and no difference in bleeding. When compared between the patient with thrombophilia or non-thrombophilia, patency and re-intervention rate is not different. For the antiplatelet, here this is a quite controversial issue because many retrospective studies support that combined antiplatelet with anticoagulant may improve patency of the stent. And for the expert, they also recommend to use antiplatelet even they don't have evidence at the time. But last year, ARIVA trial, the only RCT that we have for now, rivaroxaban combination combined with aspirin compared with rivaroxaban, it has the same primary patency and no difference in Vilata score and no difference in bleeding. So in conclusion, for now, due to lack of strong evidence and no consensus about antithrombotic treatment after stenting, so we have to, so each physician should develop their own protocol. So here is my protocol. This is not recommendation but only my preference. I start with 2 weeks of low molecular weight heparin, and if we treat the patient with DVT after thrombus removal and stenting, the duration should not be shorter than DVT guideline. And in NIVU, many studies show that anticoagulant may not be necessary, but I also give the patient with anticoagulant for 3 to 6 months. And for PTS, duration of anticoagulant may be more than 1 year. And in high thrombotic risk, longer duration of anticoagulant and additional platelet may be considered. Thank you.
Thank you very much for presentation. Discussant is Dr. Teshima. Please start.
So, thank you for your amazing presentation. I'm Teshima from Fukuoka, Japan. So, I'd like to ask about the antiplatelet drug. So according to the European and American papers, so these patients give the clopidogrel or aspirin, but we Asian people has the resistance for the clopidogrel. So which antiplatelet drug do you like to use for these patients?
Thank you for your question. If the patient, if I choose the platelet for the patient, I usually use aspirin because I think that the side effect of the clopidogrel like bleeding. So I think aspirin is better. Yeah.
So how do you think about the prasugrel or another the antiplatelet? Is this very expensive in Thailand?
I do not have that the experience about prasugrel, but I think that there is no study about the any kind of antiplatelet, so I choose the cheapest one, aspirin.
Okay, so and I'd like to ask about the anticoagulation drug. So I had you use the warfarin for your patient. So how about the drug? Do you use for your patient?
Yes. In Thailand, most of the patient, the reimbursement of the DOAC can be reimbursed in only some patients. So most of the case I use warfarin. But if the patient can pay or some patient the government reimburse, I will use DOAC also.
Thank you.
Oh, thank you very much for presentation. And because of time, we have to move to the next speaker. Thank you very much. Yeah, it's a very difficult question, and we Japanese also suffer. Which is the best treatment for that?
Okay, our last speaker in this session is Dr. Takashi Yamamoto from Yamato Vein Clinic. The title of his presentation is Endovenous Laser Ablation Therapy for Tributary Veins. Okay, could you begin your presentation, please?
First of all, I'd like to thank Dr. Uto, Dr. Imai, and all the members of Setouchi Venous Forum and Japan Venous Talk for inviting me to speak here today. I'm here to show you varicose ablation, especially how I perform it and what advantages it has. I don't have any conflict of interest at all. It is globally accepted that the concomitant removal of tributary veins is effective in achieving early symptomatic improvement and reducing the rate of reintervention. Now, the focus must shift to how. The methodology remains controversial. As you all know, there are two generally accepted treatment options for tributary veins, phlebectomy and sclerotherapy. Actually, I am deeply passionate about phlebectomy. This is a typical case of varicose veins. His left GSV is incompetent, and tributary veins are prominent on the medial side. I chose intravenous laser ablation on GSV and phlebectomy on tributary veins. Please take a close look at this photo. This was the longest vein I have ever removed. It was 87 centimeters long. I was so happy that I took many pictures. As far as I know, this is the longest segment of tributary veins taken in Japan. Let me know if you have any longer record. However, it is also well known that the conventional methods have some limitations. As a result, some cases remain unsuitable for either method. I suppose most of us started our experience of varicose ablation with cases like this. From here, I will show you the practical aspect of varicose ablation, how it is performed, what advantages it has. This 1-minute video clearly explains you how varicose ablation is performed. Firstly, puncture the vein with 16-gauge needle and let the needle go through the tortuous vein. It is crucial to let the tip of the needle stay inside. After putting the needle, insert the laser fiber to the needle. Secondly, inject tumescent anesthetic solution around the vein. You should be very careful about the amount and layer of the injection. When you inject in the appropriate layer, the solution directly replaces the space, pushing the vein wall toward the laser fiber, which enables you to ablate the vein wall with minimal energy output. Finally, ablate the vein with low energy output such as 5 watt and 5 seconds per 1 centimeter. That means 25 joule per centimeter. This low figure is enough to ablate tributary veins without causing unwanted damage for surrounding tissue. Varicose ablation has some advantages compared to phlebectomy. It has no risk for bleeding, so it requires less bandages, and you can use it even for the patient who is undergoing anthrombotic therapy without stopping the medicine. And this is applicable on those who have severe skin symptoms. This is a typical case with lipodermal sclerosis. I chose phlebectomy around the knee. I like it. However, it seemed to be difficult on calf, so I added varicose ablation here. Around the area of lipodermal sclerosis, the veins are frequently adhered to surrounding tissue, which are not good candidate for phlebectomy. And varicose ablation can be done irrespective of the surrounding condition. Varicose ablation doesn't require incision, so the scar formed after the procedure is minimum. This is a very safe method with fewer complications, only if you follow the 3 rules: stay inside, appropriate PLA, and low energy. The advantages of varicose ablation differ if you compare it to sclerotherapy. Firstly, the treated segments were closed 100%. Secondly, which is crucial to determine the post-treatment satisfaction, the thrombophlebitis formed after varicose ablation is smaller than that formed after sclerotherapy. This is my prediction. In sclerotherapy, when you inject the sclerotic agent, the vein shrinks due to vasospasm, and the vasospasm is a reversible reaction, so 1 hour later, the vein returns to its original size, even though its endothelial cells are destroyed. 1 week later, thrombus fills the inner space and cause inflammation according to the amount of the thrombus. This painful reaction is unavoidable. On the contrary, when you ablate the vein with laser, the vein shrinks due to vasospasm and irreversible denaturation of the vessel wall. And the denaturation keeps the vein smaller than its original size, which results in less amount of thrombus and less inflammation. So varicose ablation outperforms sclerotherapy in terms of effectiveness and side effects. Now, you have already known varicose ablation has the potential to outperform phlebectomy and sclerotherapy in terms of versatility and efficacy. However, the conventional options have been proved to be safe. So for the varicose ablation to surpass conventional ones, it should be safe. Dr. Uto has reported the safety profile of varicose ablation on his specific protocol and technique. Last year, we, including Dr. Uto and me, had a research to prove the safety profile of varicose ablation. The research was outlined like this, multi-center prospective. The inclusion criteria was quite simple. Only if one varicose ablation is performed, the case is included, regardless of the other options performed concomitantly or not. For example, regarding the case I showed before, phlebectomy was performed on most of the tributary, and only one varicose ablation was done here. This case was included. And then we adhere to the guideline for varicose ablation, which we established last year. Specifically, the laser fiber was kept inside of the vein, appropriate amount and location of the TLA, and the laser output was kept 5 watt. The primary endpoint of this research was postoperative adverse events, which included early ones and midterm ones. Some adverse events are common, but transient, resolving without any future consequences. On the other hand, some rare complications can result in serious clinical challenges. Let me show you the result. 1 week after the operation, ecchymosis and mild pain was quite common, whereas the serious adverse events such as infection, DVT, and skin burn were not found except for 1 case of DVT. 6 months after the operation, occlusion of treated segments was achieved in almost all cases, though nerve injury was found in 8 cases at 1 month. It was decreased to 2 cases after 6 months. These results proved that varicose ablation is at least as safe as other options for tributary veins. However, it was also revealed that the ablated veins often turn into palpable induration, which is followed by pigmentation. This reaction is inevitable, and so complete explanation for this event is required beforehand. I can conclude that varicose ablation is a useful and safe option for tributary veins, only if you follow the rules, stay inside appropriate amount and layer of TLA, and use low energy profile. Kop Kunkop.
Thank you very much for your excellent and interesting presentations. And are there any, Dr. Kaneko is there? No? Okay, so now we'll open the discussion from the floor. So do you have, are there anyone? Yeah, please.
I have the question about the nerve injury. You show in your slide that at 1 week there's no nerve injury, but however in 1 month there are some case of the nerve injury. Why if occur, it should be occur immediate after operation, all right, for the nerve injury.
Thank you. Good question. We didn't check the rate of nerve injury at 1 week. Yeah.
So you mean that nerve injury occur
I think
at
it was
1 week
more
also?
at 1 week.
Yeah, but
Yeah.
I also have the experience about the nerve injury, but how to prevent the nerve injury from the laser that very close to the nerve, especially in the ankle. Because I try also with the low setting like the 5 watt and just 20 joule per centimeter, but it sometimes it still occur, but temporarily, not permanent. What
Yeah.
is your recommendation?
I think you are doing the same thing. I think you know well. The recommendation is to put enough appropriate layer and amount of TLA around the brain.
Do you perform it intraluminary, strictly intraluminary, or sometimes you shortcut outside to transfixing or intraluminal? Do you perform the laser operation just intraluminal, even though you have nerve injury? Is that correct? Oh, it's very rare. And another practical question is because we strongly recommend intraluminal procedure. But actually, if we stick to the intraluminal procedure, we have to puncture a lot of the. We have a lot of puncture site, or sometimes we have to adapt phlebectomy. And some of the researchers declare the transfixing method or shortcut method, and even Japanese doctor performed a kind of not intraluminary, but also sometimes they performed outside the luminal. And how about what is your opinion about intraluminal versus extraluminal?
Sometimes I do perform extraluminal.
You too.
But it is not recommended just to avoid nerve injury or skin burn. And we follow the guideline, and the guideline is the Bible for everyone. So it should be very strict.
But if a guideline is for
in my
everybody,
opinion,
if it's too
okay.
strict, it cannot be useful for everybody. So that is my opinion. But maybe we have to make more research on that. I hope you can make those kind of research near future.
Thank you. Koppen Cup.
Okay, thank you for the excellent presentation, fruitful discussion, and it has been a great pleasure for us to chair the session. And this concludes the sessions. Thank you very much.